Next, upcoming, we have a very interesting session on how residents can optimize their residency. Something maybe we all wish we would have had. So I'll request the residents to come forward, please. And I'll request the speakers to join us here. Dr. Kailash Kolhe, Dr. Shamsher Chauhan, Dr. Ripul Chaudhary, Dr. Rahul Jadhav, Dr. Dept Vishwanathan, and Dr. Swapnil Walke. How can you optimize your residency? So, may I know how many of us are in the first year? No one, they're all busy working, huh? Second year? Third year? Just passed out. And let's begin.
Hello. So I'm happy to see a large crowd, and I hope we can do justice to the people who have come. So my name is Shamsher. I'm a gastroenterologist, and my colleagues, we've all done residency together. We've got Rahul, Dept, Vipul, Kailash, and Swapnil. Actually, this session that we are trying to go about conducting is how we have utilized our residency and how has that helped us in setting up our practice, and how have we learned the nuances of getting ahead in practice using our residency, which included academic and non-academic things. So there are slides today. We're going to have a free chat where we're going to take your opinions, your questions in between, and each of us are going to talk on certain things that are important for residency. We start with Kailash. So Kailash, how do you think you should start your academic reading in gastroenterology as a first year, second year, and then a third year?
So, first of all, before I talk, my disclaimer: these are not like standard guidelines. These are like what we have learned and how it is unfolding in our early career days. Each one of us are in our early career days, like 1 to 2 to 3 years of this practice. So I'm immensely grateful to Dr. Akash Shukla sir and our Sion Hospital for all those teachings. Mind you, those are the teachings which are immensely helpful in our day-to-day practice. First, I just want to tell you few tips like what to read in first, second, and third year. In first year, if you get time, you can read simple like routine day-to-day cases like cirrhosis, complications of cirrhosis like ascites, variceal bleed, pancreatitis, IBD cases. Just a glimpse how to treat, not all those details of pathophysiology. Second year, if you get, are there any residents in the first, second, third year, or all are like passed out? So if third year. So in year first and second year, we'll skip directly third year. Third year, it's not unlike all the notions that third year is only to read. It is not like that. We were used to attend our OPDs till last few days of our exams. That is most important thing. Don't lose your contact with the patients. Patients are the biggest guide to teach you. They teach you with their lives. So those are the biggest guides. They will give you n number of lessons which you will not be finding in your textbooks. So please, whenever possible, try to see patients as last as prior to 3 months. It's okay, but you continue to see the patients. In many of the hospitals, what happens? We take a leave. Of course, reading is important. We need time also, but please don't lose your contacts with patients. Akash sir made it very sure that we had contacts with our patients till the end of the exam. So otherwise, what will happen? We will our theory and we have no contacts with the patient. And in exam we get less confidence while taking cases. Second, try to present as many cases as possible to your teachers. We had more than 100 cases presented to sir. Sir used to rip us out from Joseph bolte na bal ki khal. So sir used to ask all minute questions, all possible scenarios. So those were very useful. Of course, standard textbook we have to read it once, twice, thrice to just memorize. But ultimately, what you remember in your early days of practice is what we have seen and what we have done. So reading is important, but seeing patients, attending patients is more important. I would like to just say your examination is your hall ticket, your degree certificate is your hall ticket to your lifelong exam, which is more and more difficult. Your degree is not the end, it is just the beginning of your lifelong exam. And it is the patient should be at the center of your treatment, then everything else will fall at its place.
True, true. So it's like what we call as like the third year syndrome. It's like in the first year, the most common cause of decompensation, you would say in an ACLF patient probably is viral hepatitis. And when you come to third year, you say, "Arey, to CMV hepatitis बोल सकते हैं." No, that's not what you're going to look at. You're going to look at the same three things that are coming into your brain when you're actually seeing patients. So what we instruct to our third years is key. When the patient walks into your OPD, what is the first three diagnoses that come into your mind is the same thing that you're going to do in your exams. Moving on. Now, Vipul was a tech guy inside. The tech guy in the sense, he'd know every connections in the endoscopy room. From the processor to the monitor to the scope handling to the technicalities of gastroenterology. Vipul, can you throw a light on that?
Yeah. So first of all, I'd like to thank Akash sir for giving me this opportunity.
ये disclaimer ये बोलने का जरूरत नहीं है.
हाँ, ये common हो गया अब.
I understood you are all thankful to me. That's
आगे.
Second thing that I would like to say is right from the beginning of my residency, all four of us before our batchmates, we were clear that where we would be practicing in the next post-residency period. So out of which me, Swapnil and Rahul, we were going to go to peripheries. Dept was going to stay in Mumbai. So if you plan to go to peripheries, trust me, there are no technicians, there is no one to help you out there. So until and unless you are very well versed with what you are doing with the scope, owning a scope and performing procedures plays no role. If you cannot connect the scope, if you cannot troubleshoot the scope, because what happens is in periphery, if you go give a call to the engineer will come after 5 days. A patient does not wait for 5 days. So first thing that is most important is you should be able to dismantle and reassemble the entire endoscopy setup on your own. Second is taking care of your scopes is very important. You should be able to wash the scopes. You should be able to fix minor issues. If a scope is not showing image or if the image is blurred, you should be able to at least get an idea as what is wrong with it. You just cannot sit and say, no, okay, the tech guy will come and do it. Third thing that I would like to stress upon is your residency, you see a lot of cases. You are exposed to a lot of instruments during your residency. Make sure that you know how to use and how to maintain a particular instrument so that it lasts longer. Current day, you will not understand the importance of this maybe, but down the line when you start practicing, these instruments will help you a lot. And if you do not know how to use an instrument, I am not talking about in the endoscope, I am talking about behind the endoscope, what your assistant does. So you will not be able to train someone to do it. Most importantly, when your seniors are performing some complicated or advanced procedures, make it a point that you assist them. Because the first step before learning any procedure is learning how to assist in the procedure. Once you are through with that, then you can start learning the procedure. And the last thing that I would like to stress is whether instruments or anything or scopes, when you are buying, you should also be very well versed with at what cost they come to you. Because most of the instruments, they have a printed MRP, but you can get them at much lesser rates. So it should not be that you are being swindled by the dealers every time that you are buying some instruments.
True. So, to do a good ERCP, you need to know how to assist an ERCP. All of us have assisted a lot of ERCP, so we can, I think Vipul still does his own ERCPs, he cannulates the biliary duct on his own without an assistant's help still today because it's difficult to get an assistant, and this he could learn in his residency. He knows that okay, your monitor requires a DVI port or your port requires an SD cable, so that will connect to my monitor. Which monitor I can use for cost effectiveness in your own center. These things you will learn in your residency and nowhere else. There is no book, there is no paper, there is no guideline to tell you how to troubleshoot one and how to utilize in a cost effective manner in your own center. Moving on, another important part of residency is PPTs. Anybody having problems with PPT? Any residents? No, I think
I'm not looking, please raise your hand.
that side is closed. Anybody having problems with making PPTs? So, Dipti, tell me about how PPTs helped you in learning in gastroenterology.
So an integral part of my residency was making PPTs, and I dreaded those Tuesdays. I still get blues when I think about them. So one part about the PPT is you actually have to sit, control sleep when you're trying to read and make it. The second part is obviously you don't get to sleep. So when you present and you make PPTs, you break the topic into multiple parts, you read them in detail and then you make the slides. It always starts with copy pasting and then you know how brutal that is. So on the day that you're presenting or when you're making it, you read every topic in so much detail that it sort of plays in your mind when you just hear that topic later on. And you, at the end of residency, we have a bank of so many PPTs that it helped us prepare for our exams and it helps us even now. If you have something in doubt, you can refer to them. It also improves your public speaking abilities and all the criticism that you take. Just take it in your stride and improve for the next PPT and for everything else.
So, Kailash, how have you handled criticism in gastroenterology? I know it's a very polished way of speaking these things, but how have you handled that?
First of all, accepting criticism is very difficult. Yeah, it feels bad, but when you think over it, what went wrong, actually that criticism will improve you forever. So there are a lot of mistakes we made, lot of criticism we faced, but down the line in the practice, I'm experiencing that is helping me immensely. So if you want to avoid, starting from how to talk with the relatives, how to explain to the relatives, how to talk with the patient, how to prognosticate the patient, these all things have helped a lot. So criticism, as Dept rightly said, use it in a constructive way.
I can add a point on how about the PPTs. It's like I'll give an example. Like when I was a resident, we made a PPT on PERT. Okay. Now when you open Schlesinger and you see PERT, it's just probably a paragraph or two, and that's not what exactly PERT is all about. It's a whole different science. It's a whole different pharmacology. And when you go into the depths, and then you read and then you make a PPT, that's probably the only time you're going to go in so depth about a simple particular topic. And then once you conglomerate all of that data and make it into a PPT, that PPT stays with you for life. So you don't have to remake your PPT. एक बार बना लिया, बहुत अच्छे से बना लिया, you've presented it, and that's the end of it. And that stays with you, and you can always go back and refer to it.
I'll just add one point, just the yesterday's experience. So, chronic pancreatitis case, the questions I was asked in one of the PPTs was what are the causes of pain in chronic pancreatitis other than pancreatitis. So, I had a patient who was in pain for last almost 15 days, severe pain. It was not getting controlled with tramadol infusion, fentanyl patch and whatnot. So, I started thinking something else is there. And CT reports, CT plates were only suggestive of only pancreatitis, but I could see the lymph nodes which were not fitting in pancreatitis. I could see the stomach thickening which was not fitting with the pancreatitis. So I did his ogidoscopy. It was suggestive of diffuse growth in stomach, which the histopath came out to be adenocarcinoma. Now this was responsible for his pain, the pain which was not getting controlled for last 15 days. So how residency helped? So in residency, we were asked what were in PPTs, and we used to attend clinico-radiological meetings also. So that helped me to diagnose the exact condition of the patient. So this is importance of discussion, multidisciplinary discussion.
Exactly. Important point. Read your CTs. That when you are in a first year, you will in MD we've not read CTs. रिपोर्ट देखा, ओके गुड, ये है, अच्छा इसको ये कॉक्स है, ये pulmonary edema hai, this is some lesion in the liver. But when you are in your first year, you have time. The first year is the most important part of your residency because you have the most connect with your patients. जिसका भी CT हुआ, take that CT, put it on the view box, try and see things. You know why? Because many a times you'll pick up things probably the radiologist might have not. And in your medical college, if the radiologist is like a resident like you, he may or may not have reported certain things, and you'll get a fair idea on how to see a CT scan, which is very important. See your own CT scans, see your own MRCPs. It will really help you down the line in practice. It should be a part of you, like you reading CBC LFT reports, see the CT plate. It will make a big difference in your practice.
So on this note, I'll just add one point. I think Kailash is the person who spent the maximum time in CTs.
For multiple reasons. So, coming back to patient management and patient counseling, I think Swapnil was the best guy we had for these things. Swapnil was one person who would really have a good chat with the patient. Swapnil, how has that helped you in your career today?
Basically, before starting about counseling, I just want to know, be faithful to yourself. When you are faithful to yourself, then only you can give results to the patients and their relatives. What you are doing to the patients is most important. What you are going to do rather than what are the complications patient can have or relatives can have is most important in the practice. In science, we did our residency. During residency days, there are very few occasions where relatives or crowd gets rowdy. But in practice, the scenario is totally different. So, counseling is most important part of the practice, what I think. I see more than 50 patients per day, as good as in science. But giving time to patients, what we learned in residency is very helpful in the practice. Because right from the counseling for the OPD patients to the procedure, post-procedure, complication procedure and death is a very important part of the counseling. And right from simple cases, dyspepsia also, counseling matters. The counseling helps in treatment also, and counseling is important for the relatives counseling also. My mindset also.
True.
So
The first year is the most in contact with the patient. So in first year, when you're sitting down, you're writing your CTR notes, you're writing your treatment sheet. That is the time you connect with your patients. The second year is the consultant fee. When you are in second year, you are taking your rounds, you are discussing it with, you discuss the management plans. You don't understand something, you go back, you read, you come again and discuss this with the patient. It makes a lot of difference because you know what you're going to do in your practice. Because trust me, when you go out and practice, you are all alone. And that, if your knowledge is there with proper understanding of your subject, that will make a big difference. Okay, now Rahul, you have what is the impact of bedside teaching, bedside clinics in your practice today?
So I remember my residency day. Those were called as Monday blues. Sir used to come around 8:30 in the ward, and we used to spend whole Sunday in arranging files and everything. If there is a problem in some patient, so sir will ask minute things tomorrow about the patient. What has happened? What has happened with this patient? What has happened? So in residency, there should be grand rounds. Once a week in ward, you should take grand rounds, and the other thing is that in second year you should spend time with the patient. That is very important. So minor complaints when you are sitting in the ward and patient is getting desaturated in front of you. That has happened with us. So you have to spend time with the patient. That is what very important in the residency.
I think maybe talking more, learning on the go, that really helps in residency. And even when you are reading, Rahul, what is the impact? How did you know ki, acha, this journal we have to read, this RCT we have to read? How did you decide on that? How was that done in residency that helps you today also?
So we used to have journal scans first.
You guys do journal scans?
Yes.
Yeah.
So you have to see journal scans. You have to see first abstracts, and from those abstracts you should select some papers. So while reading papers, you should see methodology in detail. That is very important. How they have conducted a particular study or particular trial. Then you should see results in detail. Read supplementary material also in detail of each new study, which you feel that is important, and about the landmark trials whichever came over the period of time. So each and every journal have some landmark trials. So you should go and read those trials in detail with supplementary material. That is very important. Regarding the journals for gastroenterology, I feel gut, gastroenterology, then CGH, clinical gastroenterology and hepatology. These are the important journals that those you must read. For hepatology, our Hepatology International, Journal of Hepatology, clinical and experimental hepatology. These are must. Means above that you can read whatever you want, but these are must. For endoscopy, clinical endoscopy, GI endoscopy and endoscopy are means important, and clinical endoscopy. So these are the must read journals during your career and during your residency. So, and another thing, what about the textbooks? So ideally you should finish your Schlesinger and Chips in second year. Though I have not done it, but it's not the easy thing while doing PMC residency. I tell you clearly, it is not possible, but ideally it should be like that, because we had regret about it. So try to read. Yes.
I'll give you a simple way to read journals. You know, you have this app called Read by QX. You all have that? You have any? Nobody? Download it today. It's a free app. You can go on that. You can subscribe to journals, and you can just run through their abstracts. In your residency, suppose if there's a data on sRNAs or if there's proteomics, you can probably put it for a later date. If you're looking at new drug trials that have come, yes, read that. See the methodology of, as Rahul said, how they have done that trial. After you see the methodology of that trial, see the baseline characteristics. If the baseline characteristics of the patients in that trial match your day-to-day patient, that means yes, you can probably apply the results of this trial to your day-to-day practice. Then you see the results, you see the primary outcomes and the secondary outcomes, if that is actually going to help in your in long term. I'll give you a simple example. There was this study that had come out which said sorafenib is equal to TARE. You've heard that? You've read that? In Lancet, big paper. Sorafenib is equal to TARE. And when you read that paper, you probably understand that 30% of the people receiving TARE did not receive TARE and received sorafenib. And 50% of the patients in the TARE group had multicentric HCC, where the smallest size, and that was about less than 10% in the sorafenib group. So you know there is probably some discrepancy, and that is why the TARE was equal to sorafenib. So this, as a clinician, you will come to know only in residency when you read the whole paper. That is why you cannot take a paper on face value, and that is why you need to read this, and this, trust me, will become a practice as you go ahead. Because in practice, you might not get the time, but you have to make time to read these landmark papers so as to give a conclusion, because you want to read the patient. Yeah. Kailash, can you give me a timeline on how you're going to read Schlesinger or how you have read Schlesinger? Because that's the way you start reading in gastroenterology.
As Rahul said, it is not possible to finish it in second year, but try to finish as much as possible. But yes, by mid third year you should have finished your Schlesinger, because you need to revise it. First reading is not going to help you. Second reading probably 30-40% you will retain. third reading you will be retaining
Third reading.
60, 80%. But yeah, you have to take that extra effort. And mind you, you will read Schlesinger only during your residency, the whole book. After your residency, you won't get time to read the book. Nowadays, also, if some patients come, some atypical patient come with atypical presentation, I go back to Schlesinger and I realize ki, oh, this can happen like this one. So many things are there which are again I have to read again, and I realize that some things I haven't read. So it is the magic of Schlesinger or any textbook.
True. So I can give you a little timeline. I can say that in second year, first year, if you get time, good. If you're a DNB, if you're at a DNB institute, probably you'll get a little more time than DM. But if you get time, start off. Forget the first 10 chapters in the second year. छोड़ दो. Nutrition, obesity, वो सब बाद में. Start off with the symptomatology because that is what you're going to see in the OPD daily. That is what is going to really help you. Then directly go on to esophagus. Esophagus, stomach, pancreatobiliary. Finish it in second year. This is the timeline. You finish it in second year, and trust me, if you read 5 pages a day, you can finish it off. हो जाएगा. Diligently 5 pages a day, you have to put in it. If you 55 pages, but if you read 10 pages a day, trust me, you can finish it off. EASL guidelines, every year new guidelines will come on different topics. You can still finish it. ACLF guidelines are there, APASL guidelines are there. Very important to read daily. You can't leave it till weekend. Weekend aate you will say, I'm tired. Yes, trust me, practice is more tiring. Once you go into practice, it will be more tiring. But this is the best part of your lives. Trust me, enjoy it. Study more over it because इससे ज़्यादा पढ़ाई और नहीं होने वाला. What do you say, Swapnil?
You are much busier in the practice rather than the residency. Residency is best time of your life. You cannot get time in the private practice. You do not spare any time, anything for the private practice. Do everything, every possible thing in the residency. What you learn in residency, each and every minute of residency is helpful for whole of your life. It is most important part. There are so many things we have just seen in residency, but we are doing in private practice day to day. Right? For example, colonoscopy. We haven't seen colonoscopy in our residency. I did colonoscopy in Solapur. It was just so what we observe in daily practices matters. That is very important thing. Just follow your seniors and teachers is very important thing in residency.
True. So, given the whole set, you guys have any questions? You can always ask us. You can just any questions. It's like a cakewalk. Residency. Yes.
I'm Michael from KM.
Yeah, I met. Of course, I know.
So I did my MD residency in KM and then I did my DM residency in KM. And after I finished it last year and then realized there are no good residents or bad residents anywhere, especially not in gastro at least. There are residents who work hard, there are residents who work really smart. So if you work smart, it is for you. If you work hard, it is for your patients. So hard work or smart work? That's my question.
Hard and smart work. The why? The reason I tell you is, if you are working hard, your patients are going to benefit. But if you are working smart, your colleagues are going to benefit as well. So if you see, there are no just single resident. So each one has this defined role. If I was working hard, maybe Kailash was doing the smart work, or vice versa. We were running around, we were seeing patients in their 4 groups, they were doing the same. So you need to understand what caters. You need to become hard working on particular day. You need to be smart working on a particular day. It's a dynamic equilibrium. You need to find that out. But in the end, you need to remember this one thing. You are doing it for someone's life. You cannot cut corners. You cannot. And the most important thing is your reading will save a life. Forget everything else. If you don't know, you will not know. पेशेंट की लाइफ से ज्यादा जरूरी और कुछ भी नहीं है. One thing, simple example I'll tell you. You see a lot of patients with gastrocolic reflex, increased gastrocolic reflex. Can you tell me the treatment of choice? Anybody? Exactly. Ondansetron. Because that's the only hormone, serotonin, that works and causes gastrocolic reflex, and trust me, it is only given in Schlesinger. बहुत ढूंढा, बहुत नहीं मिला, and then you say, अरे तो Schlesinger के line में लिखा है in those bad chapters of small bowel mechanics. Good. So this is what will make a difference in your life. If you read perfectly, एक बार पढ़ा होगा आपने, you will never forget it. And you cannot say कि I've left this, not IMP, this is not important, ये कौन पढ़ेगा? You are playing with a life. You cannot do that. Forget everything else in this world. That patient has come to you for you. You cannot leave it to fate.
Two things I'd like to add. You are working as a resident for your patients, that is very true, but you are working as a team. Everybody is human. It is bound that disputes will occur. It is bound there will be misunderstandings. But at the end of the day, your batch should stand together no matter what are the consequences. That is the first thing. Second thing is, never ever during a residency lie or make up reports just so that you escape something that is going to come on you. Never ever do that, because this will come and bite you bad in your future, because then you get used to cutting corners. So these are the two things that I'd like to say in the end.
Rahul, you have to say?
It's not about smart work or hard work. In the end, I feel the patient should not get compromised. You do whatever, but there should be a betterment of the patient. You do either hard work, you do smart work. Patient should not get compromised. That we have to take care. That's what it is.
Any questions you have? Anything that you would like to say, like that has affected a part of your residency, making PPTs at 2 in the night, something of that sort? Anything that has, that you say that it is affecting me as a human? You can give your thoughts. Anybody?
Early post residents also can ask your doubts.
So I'll leave the end comments. Yes, sir.
I'll just add one more point here.
Yes.
See, everybody has their own strengths and weaknesses, and when you are in a batch, you need to understand each other's strengths and weaknesses, and don't compare yourself with the others. That I am doing so many hours of work and he is doing so many hours of work, or I have seen so many patients in that time, or he has seen so many patients in that time. You have to use each other's strengths in a complementary manner. So I'll give you an example of Shamsher and Kailash. So of these two, Shamsher was the true hard working guy. Means you leave him with the patient, he can spend 24 hours with the patients. And so that was his. But you ask him कि यार ये 4 काम हैं, other than seeing patients, ये शाम तक करके चाहिए मुझे. He would struggle. Kailash was extraordinary in arranging things, mobilizing with jugaad. So then they used to divide their work also in those ways. So even if I told Shamsher, आज ये चाहिए मुझे, I told, he would say yes. And I know most of those works which were done by Kailash actually. Although they didn't know that, I know that he has passed on that work to Kailash and Kailash has gotten it done. But I knew that it was Kailash who was doing that job. Similarly, a few things which I used to tell Kailash, यार मुझे ये articles का ये बना के देना जरा PPT. So I knew कि उसने नहीं बनाया है, वो शमशेर ने बना के दिया, because I knew the language, the way, the style जिसने बनाया. So, but that is how it should be. It doesn't matter, because they had that sort of understanding between each other. So they both of them mutually complemented their skills. And it was the same with the next batch also. So all 4 of them are here. So each one of them had their own strengths and weaknesses, and they complemented each other beautifully. And people perceive that this one is sir's favorite or this one is not the favorite. Ask them now retrospectively, do they think that there was any differentiation whatsoever? Never. But at that time you will always feel. But it is because I can see who's strong in what, and accordingly you will get the job assignments. It is not about favoritism, it is about using your strengths. And that is why I'll give you an example. Why Tendulkar was one of the best players that the country has ever had, but one of the worst captains. And why Ganguly or Dhoni were the best. It is because Tendulkar expected everybody to play like Tendulkar. He sent Javaga Srinath to bat at number 3 position because he thought that he can slog and increase the run rate. But Javaga Srinath is a bowler. You have to make him bowl. You can't give him added responsibility of batting. While Ganguly, let Sehwag play the way Sehwag is capable of. And this is very important because tomorrow you will be leaders wherever you are. All of them. I mean, they are all less than 5 years into practice and they are all number 1 wherever they are practicing. Why? Because they know their strengths and they have played on those strengths. That is what it is important. So you identify your own strengths, you understand each other's strengths and weaknesses and cover up for each other rather than, thinking this is that and this is that. So go with open mind, work as a team like what they said. I think that is the message which I would want to add.
And just one last line I would like to add. 5 P's are very important in your practice. 5 P's. First and foremost is patient. You should be patient-centric. Believe me, if you treat patient as someone like you should have empathy, not sympathy with the patient. The patient will bring more patients. Second P, politicians. Use them as a pinch of salt. Don't over attach with them, but at the same time do whatever you want. Police, prominent people like bureaucracy and all, and patrakar like journalists. If you keep them in your good faith, somebody will come if some scenario happens, somebody will come for your help. And mind you, in a day-to-day practice, anything can happen at any day, at any time. So if you have all these 5 P's in your hand, it will be, very, very beneficial. I'll end my talk just telling the day before yesterday's experience. I had 2 patients which died, within half an hour. One was like decompensated cirrhosis, end-stage liver disease, and other was like pancreatitis, who died suddenly of acute cardiac arrest. Suddenly. I was about to discharge him after 2 hours. So the sudden death is very difficult to handle as far as private practice is concerned. So I counseled them, but they had a lot of queries how this happened. Patient was improving. अभी तो हम घर जा रहे थे. अब ये कैसे हो गया? So I told them acute cardiac arrest can happen at any time. If you have any doubt, you can go ahead for postmortem. I'm ready. I'm ready for everything. Suddenly the second patient's relative came. He told them, especially mother, she told them that I have lost my young son. This doctor has done best possible thing for me. I have seen her working for you also. You don't know he was behind everything. So that suddenly calmed down everything. So the relatives who were in aggressive mode, they straight away said, "We are sorry, sir. Anything." I told them anything can happen. Even I might die also of sudden cardiac arrest. That is how you can't predict any patient what. In fact, every IPD patient until you discharge, you can't predict what will happen. So this as Swapnil said, as everybody said, this counseling has helped me a lot. Patient has helped me to save from this critical situation. Just last week's incidents.
Just one thing to add. Very important thing. Paperwork complete karo. Your consent forms, your daily notes. Trust me, when you write those daily notes, सिर्फ writers लिखने का मतलब नहीं है. What you have conveyed to the patient, whether you have explained the pros and cons of a particular procedure, whether you have explained how complications can occur and what you can do to them, it should be documented on the paper. You learn this practice in residency only. बाहर जाके ये कोई सिखाएगा नहीं तुमको. You make a good detailed consent form. We have our own detailed consent form. Rahul ने इतनी मेहनत की, made a good detailed consent form of every procedure. Upper GI अलग, colo अलग, US, ERCP, different forms. You make these consent forms. You document on paper your daily notes, because when you are going out and seeing patients, you can't say vital stable, paraptosoft, nothing there. Document that you have talked to the relatives. Document that what they want. If you don't do this in residency, And in the end, God forbid anything untoward happens, the paper is there to save you. Nothing else saves. सब मुकर जाते हैं, paper बचाता है. So you like to act on that?
Thank you.
Thank you all for a patient hearing.